Um, but her care was sort of complicated by some substance abuse issues. And I thought it would be a good case because it's not the setting where you would typically address a substance abuse problems, but it kind of demonstrates, I think, really well how problems in that area can spill over to other areas of care. So this was a young 26-year-old female patient who came in for a routine pap smear and like women's health screening in September of last year. And she had no insurance. The health department had been providing insurance for her in the past. One of the things she brought up with the nurses as she was being roomed was she was concerned about some textural changes occurring in her breast. So, you know, again, we were there to address her kind of gynecological needs. She was amenorrheic on Nexplanon, which was put in about 18 months prior. So there was no real concern about pregnancy or anything. And she didn't have anything else on review of systems. Let's see, can you scroll down a little bit? Okay. So several weeks prior to this, she had come in for an asymptomatic STI screening and didn't really give any reason, but she did opt to have the HIV testing and the Hep C testing done through the Focus grant. But her gonorrhea, chlamydia, syphilis, HIV, Hep C was all negative. And so we were almost a little bit surprised that she came in because this is sort of the hardest patient population to get back in for routine screenings. She had a long-acting reversible contraceptive, you know, she didn't need refills on oral contraceptives. And she had just had all negative screening for the STIs. So, you know, this is the type of patient we typically expect to no-show, and she was there half an hour earlier. So we were kind of wondering if something else was going on. Would you scroll up a little? So when we were talking about the breast tissue changes, she explained that she had been injecting heroin into the breast veins daily. And she was also using intranasal methamphetamine pretty regularly, although not daily. So she was living at home with her parents. She was attempting to hide the injection drug use from her parents. Although her mother was the one who drove her, she was out in the waiting room, and the mother was aware of the methamphetamine use, but not the heroin use. So she, you know, while we were kind of discussing that with her, she said that several people in her social circle had had fatal overdoses over the last year or so. And she was very concerned about her drug use and she wanted to stop using, but she didn't feel that she had any treatment options due to the lack of insurance. So we can scroll down. She didn't have any other comorbidities. So on exam, her BMI was within normal range. She didn't look particularly malnourished. She wasn't overweight. She didn't have any skin lesions that were, you know, obvious on gross exam. She didn't have any thinning of the hair. And she was dressed in clean clothes. Like, she didn't look disheveled or anything. She seemed very pulled together, despite the fact that she had used methamphetamine that morning. She had good dentition. There was no lymphadenopathy in the neck. There was no thyromegaly. I did not look in her nose. That would have been a good thing to do. Her lungs were clear to auscultation bilaterally. She had a regular heart rate and rhythm. There wasn't any tachycardia. Normal abdominal exam. We can scroll down. And then on the breast exam, there was a puncture mark evident several centimeters superior and medial to the right areola. On palpation, there was a palpable vein that felt slightly fibrotic is the word I would use. There weren't any masses, there weren't any palpable abscesses or any fluctuance, nothing suggesting really an infectious process going on. And there were no signs of skin or tissue breakdown. There wasn't any like erythema or warmth in the surrounding area. So I guess the question I would kind of pose to people is, given the resources available in the health department setting, what would be the most appropriate next step for this patient in addressing her substance use? And would any specific workup be indicated for her breast complaint? And I guess, how does injection drug use alter the differential diagnosis?
Awesome job, Maggie. Thank you so much. We appreciate you presenting today, and that was an awesome presentation, so thank you. We'll open it up for any clarifying questions from the group. Anyone is welcome to unmute or chat in any clarifying questions.
Just a question on health insurance. Was there any obstacles to her getting state insurance? She just hadn't done it yet, or was there a reason that she couldn't have that?
So we were kind of wondering that, and this played into where we ultimately recommended she went. I felt like there was more of a perceived barrier than an actual barrier. Like, I think she could have gotten a state insurance card, but just, you know, no one in her life had kind of suggested that to her. And she felt like that was disqualifying for pretty much any treatment option.
Such a good point. Perceived barrier versus actual barrier. Yeah, because that would be my first thought of how can we quickly get her support, because that will open up, you know, kind of multiple treatment options for her.
Thank you, Katie. And we got a chat in, Dr. Reynolds asking, where does she live?
So she lived, I think, outside of Clarksburg in Harrison County, and with her parents. So she had like a stable living situation. That being said, you know, her injection practices, it was kind of a double-edged sword. She was actively hiding it from her parents. Mom was more in the loop than dad. Yeah. And she expressed a lot of concern that her father would find out. And I think she was a little bit worried about how that would play out.
Sure. I was just asking because we have a study at WVU where she would be eligible for meds. We would actually pay her. Well, I wouldn't pay her, but the study does.
Very cool. Thank you for sharing that, Dr. Reynolds. And any other clarifying questions or comments or any recommendations from the group for Maggie?
I was just going to say that, you know, when a patient presents and says they're interested in getting help for substance use, you want to, you know, take care of that right away while they're interested, and pursue referring them to the appropriate treatment right away. You know, to kind of take that moment when they're interested and offer them something.
Thank you, Dr. Hirschler. Any other feedback or recommendations? And I'm happy to pull the case back up as well to share those. I think we had 2 or 3 questions. Let me pull that up.
Oh, thanks for pulling it up. That's helpful. Yeah, totally agree with Dr. Hirschler about kind of striking while the iron's hot. And I appreciate she was sort of worried about parents finding out about her. Sounds like the whole picture of it, but maybe if mom is aware of her methamphetamine use, that could be the door to get her into treatment. And she could tell mom that's what the treatment's for if she's not yet ready to be completely transparent about what she's getting help for. But that could kind of, you know, hooking her up with a medical card. Dr. Reynolds also had a great suggestion. So the study is folks don't need health insurance to come in for that. And then I think also Derek with Health Right, don't you guys have did I hear, I feel like I just learned this on last Thursday or Friday. There's a way for folks to get grant supported funding for treatment, even if they don't have
So there is a SOAR funded program for uninsured and underinsured. So it's anybody who does not have any kind of medical coverage, and it's anybody whose medical coverage does not cover the treatment, up to 400% the federal poverty level.
Yeah, perfect. Thank you, Derek.
Thank you both very much. That's very helpful and informative.
Another thing I would add is how important it is to provide an overdose rescue kit, in the meanwhile, until she initiates treatment with something like Suboxone or methadone, to be sure that she has an overdose rescue kit.
So this is where kind of this particular case ties into broader policy issues with the Harrison County Health Department, because they had a harm reduction program in place. It got a lot of pushback from the local community and was actually shut down by the city even before there was statewide legislation kind of damping down harm reduction programs. So this is someone who, like 5 years earlier, could have left with clean needles, they could have left with Narcan, they could have left with like instruction on safe injection problems. And that was no longer an option that was on the table for us. And I think this kind of demonstrates like what you lose by getting rid of a program like that, because I don't really know where she went from this encounter. Like, we came up with a plan for her and she seemed like we had buy-in. But if there were a harm reduction program in place, then we would kind of have that follow-up and we'd have a sense of where things were going and have more opportunities for repeated contact. And I mean, I think we were kind of lucky that like she already had sort of a rapport with the nurses, because she had come in 2 weeks earlier for the STD testing. And honestly, I feel like the fact that she was able to or willing to come in and have this discussion with us is really like a testament to how compassionate and how good the nursing staff is at the health department. Like, she came in for a complaint that a lot of people find like embarrassing and stigmatizing, specifically STI screening. And she was willing to come back in 2 weeks later and kind of lay it all on the table. And I really feel like that's a credit to the nursing staff there.
Just another thought is, I can't imagine this is a rare occurrence in today's world. And there needs to be a system in place to refer these people to appropriate treatment. So that's a terrible need that needs to be addressed in that area if there's not somewhere to send people.
So ultimately what we recommended she go to HealthRight, because we felt like she needed to go someplace where the insurance aspect could be addressed and the harm reduction could be addressed. And ultimately, therapy with Suboxone or something could be initiated. I don't think she would have, again, the lack of an insurance card, I'm not sure it was a real barrier, but to her that perceived barrier seemed really high. Like, she kind of reiterated multiple times, like, I'm not going to be able to go to a rehab. And she was kind of hung up on that. And we felt like she kind of needed to go somewhere where people could meet her where she was. And what we focused on was coming up with a really tangible plan for her. And she said, either her mom would drive her to Morgantown to HealthRight, or she could get a friend to do it if the mom wasn't able to do it. So, we had kind of a plan and a backup plan for transportation. And she seemed willing at least to go like in the next week.
That's excellent, Maggie. Thank you. Thank you so much for sharing that. Were there any other questions, Maggie, that you wanted to have addressed or maybe discussed with the group about this case in particular? Doesn't necessarily have to be the ones you asked on the case form.
I guess any recommendations on just addressing like the polysubstance abuse in an outpatient setting, like both meth and heroin. And I think she actually mentioned to us that she felt like she needed it seemed like she was using the meth almost to stay clear-headed while using heroin. I mean, that's a bad way to phrase that, clear-headed, but like she seemed, you know, we had a very coherent conversation with her, and it really seemed like she was using one to kind of offset the other. And I think that's hard to address in an outpatient setting. So any insight into how better to address that would be appreciated.
I mean, it's not uncommon for our patients to use multiple substances, and patients have ideas about, you know, what one drug will do to help them get off of another one. I think the issue's already been addressed in just that she's ready for help. So it doesn't really matter to me, you know, what other substances she's using, as long as she can, you know, engage in treatment. And then in treatment, sometimes patients will have the idea like, oh, I got to get off heroin, but meth is okay. You know, this is something that we work with one piece at a time, and, you know, try and build that quality life that we want for all the patients. So I don't know if I answered your question.
Yeah, and I think that kind of goes back to just getting her to take the next best step. Like in that setting, we couldn't address everything she needed to be addressed, and we tried to just direct her someplace where multiple aspects could be addressed.
Yeah, I think, you know, the expression I see on your face is the kind of the feeling I used to have, because I didn't know how to help these patients. And it, you know, as a physician, it's really, really frustrating because you can see the need and you don't know what to do with it. So, yeah. So, you know, bring it to an ECHO conference.
I love that, Dr. Reynolds putting in the echo plug.
I guess the other question is this, I'm kind of interested, how often do other people see this as an injection practice? I raised it actually with the pharmacy team I was just working with, and they said Ruby had a really bad case of someone with necrosis in the breast area because they were injecting there trying to hide their substance use from a romantic partner. And it looks like there are some case studies of specifically people like injecting meth in the breast and getting fat necrosis or skin necrosis. And does anyone have any experience in that? Or like how you would widen the differential of a breast complaint in someone who's doing that injection practice? Okay.
We got a chat in from Santa. Thank you. She was agreeing that she also saw a patient in 2020 with breast abscesses, injection of heroin.
Yeah, we see that as well too in Charleston.
Anyone else? Were there any other comments or thoughts and feedback from the group about this case or anything similar to it? Maggie, any other questions you wanted to sort of have addressed today?
No, that's all. Thank you.
Excellent. No, thank you so much. We're so excited when we get cases in, and you did such a wonderful job and had really great follow-up questions as well. So it always helps with discussion and everyone learns a little bit of something. So we really appreciate you today. Thank you so much, Maggie. All right, so Phil, I will pull up your didactic for you. Just, you know how it goes. Just let me know when you'd like me to advance to the next slide for you. Thank you.
Thanks. So welcome to my living room. I have a sick kiddo at home with flu type A. So I will try to get through this without interruptions. Yay. So today we'll talk about some confidentiality in groups. I'm one of the lead therapists out at BMed up at in Morgantown. So this is confidentiality in groups. Next slide, please. So what is confidentiality? Obviously, it's something we talk a lot about, regardless of the area of health that we work in. But it's a state of keeping or being kept secret or private. And then it's, especially in the era of COVID, where a lot of us are doing Zoom groups or other forms of telemedicine, it's something that we really need to talk about in groups frequently. What happens in group stays in group. That means we should also be having them respect that, their environment. So if they're, headphones or things like that, to try and help maintain confidentiality. Other things that we can do is have them do like a sweep of their room if we feel like folks are in the background. But if maintaining confidentiality in group is going to help kind of maintain that safe environment for folks to be able to talk about, issues that are important to them, that maybe they're not ready to talk about outside of a clinical setting. And my dog's about to bark at the mail truck that's driving by. Next slide, please. So in our code agreement, and Katie or Olivia, correct me if I'm wrong, but I understand that those I see and what I hear in treatment is strictly confidential. Violation of confidentiality may result in being referred to a higher level of care or outside treatment provider, and may subject said participant to other penalties and sanctions so prescribed by laws and regulations governing the protection of individual confidential information. So this is something that all of our patients coming into COAT sign before they even go into their first group. We spell out how serious we take confidentiality. One thing I let our patients know too is that's not just for them, that's for us. So they can trust that I'm not going to go and talk to our registration specialist about what they talked about in group. The only people I'm going to speak to is going to be the treatment team, the doc, the case manager, and the therapist. Other than that, there's no need for anyone else to know what's talked about in the clinical setting. Next slide, please. So a little bit more about telehealth. We do want folks to be in a space that is relatively free of distractions, minus cranky old dogs, where they can speak freely. They can wear headphones or keep the volume low to prevent others from hearing, especially, obviously what other people are saying. Ask others in the environment to not disturb them during the group. So right now, my daughter is laying in bed playing iPad games, aka Amazon Kindle Fire thing. Ask others in the environment to not disturb them, like I just said. Form policies around call-in and video on-off options. So in group, we really do want folks to continue to be on video at all times. Then we can, see what's going on in their environment. We're going to create detailed consent forms so patients are aware of risks, benefits, and limits to confidentiality. So we always can't control certain aspects of our environment, but we can take steps to control the majority of our environment. Sessions are conducted outside of controlled office settings, and then how to handle breaches in confidentiality, including non-group members coming into the room and then overhearing a meeting. And we can all handle that a little bit differently. Some might get a warning of, hey, can you ask them to leave? Or we can just remove them from the group. Next slide, please. So when can we break confidentiality? So in certain circumstances, we can override our duty of confidentiality to patients. So if a patient's at risk of self-harm, information suggests that a patient or client is posing risk of harm to someone else, cases of child abuse, adult abuse, neglect, financial exploitation. And this is one of those things too, I really, as a therapist, like to let folks know where my confidentiality lies and that, I have a duty to warn. It's just, how do we communicate that? We don't want to scare people away from being open and honest and telling us they're having suicidal thoughts or homicidal thoughts. But there comes a time where we might have to do a mental hygiene petition or contact the sheriff's office. We also want to seek consultation either from a colleague, a supervisor, whether clinical or administrative, but we also want to follow our agency's guidelines and procedures. And then in good faith, So when we're making something in good faith, not out of retaliation, oftentimes we are protected. If I really feel like a patient is going to go and harm somebody based off what they said, and I call the sheriff's office, hopefully I've documented it well enough, but that's a good faith reporting. Next slide, please. Some potential breaches that we can encounter, and I'm sure there have been others that over these last couple of years in telehealth, you all have encountered as well, but a group member attending group in a non-secure location where a non-member can see or hear the group, a member recording or taking a screenshot of the group members, a member using recorded material to share the identity of or blackmail the group or a specific member. And those would be all things that would fall under the confidentiality piece of the agreement, and that person could be removed from the code setting. Next slide. So just a couple of questions to pose for hopefully some conversation. What is your agency doing to monitor for confidentiality within group settings?
And Phil, I will monitor the chat for you if we get any
Oh,
responses.
You're the best.
Okay.
And remember, I'm a therapist, so I'm completely comfortable with awkward silences and pauses.
Same with us for echo, so we'll wait. But no, feel free to do the raise hand feature or unmute as well. We're a friendly group, so.
Feature's a little more comfortable. I'm not as good at it.
So it looks like Nikki literally watch and listen for other people in the background. Yeah, I also like watching for this, where they look off ahead and start shaking their head. We've all seen it if we pay close enough attention. Like right now, my dog's licking her paws because she knows I won't snap my fingers at her. But a lot of us, we pay attention to those body cues or also what's being done in the background. Yeah, thank you, Nikki. What else is your agency doing?
One thing we do here that Olivia and I do, since we run our orientation group, so these are the folks that are coming into COAT for the first time, we're aware that some of those people they've never participated in group therapy, much less group therapy on Zoom. So they may not be aware of the kind of, tricks of the trade that we can help them see. Here's some things that you can do to essentially help your group members know that you're being confidential. So, try to have a wall behind you where, no adult can walk behind you, and why headphones are important. And so we're not yet to that monitoring phase, but really just kind of educating them. Here's some things you may not even are aware that sort of just help people feel a little bit better about it. Here's some things you can do for that.
Thank you, Katie. And then Mary, we have confidentiality policies, and both therapists are also guided by NASW confidentiality and NAAD. Yeah, that confidentiality requirements. That just wasn't rolling off the tongue today. Yeah. So confidentiality is just not limited to the patients. Even pre-COVID, I would talk to groups, living in West Virginia, and it's sometimes we see folks places, and so it's, hey, if I see you in public, I'm not gonna say hi to you or initiate conversation unless you say hi to me first. I walked right by clients who avoided eye contact, looked down and away, and so I looked the opposite direction. Others have walked up to me in the middle of the food court at the mall and wanted to carry on a conversation about their week. Those are fun conversations. So it can happen different places, and if you're not comfortable with it, then it's addressing it in the next session if you didn't address it prior to. And then Jenny, we're meeting in person, but we're trying to bring it up in group on a regular basis, especially when we have new members. Yes, I agree. It should be discussed frequently. Everyone should know that expectation of confidentiality, especially if we require patients go to NA meetings or self-help meetings, you don't want them walking up to each other and asking them about their medication or because they might not want people to know that they're taking a medication yet. How have you handled an issue pertaining to confidentiality within group? Do you do the kind of the warning, or is it automatic removal from the group? Are there other ways that you have found to kind of handle confidentiality in that group setting?
I know that I personally in groups, I do a lot of the, hey, it looks like you're talking to somebody. Can you do a 360 room sweep for me? I just have to make sure things are confidential. I do that a lot. And then I'll do like after I do that, I'll just give a reminder of how important it is for confidentiality. That way the whole group kind of gets that again.
Yeah. And then Nikki will stop the whole group. Yeah, until the other people are out of the room.
Thing additional we've done, and I'm aware some places aren't able to do this based on how many groups you have, but when we find out that folks in a group are related to each other or neighbors or third cousins or whatever, if we get the sense that that's going to be difficult for them, we'll try to split them up in separate groups so they're not put in a position where they're going to accidentally break confidence, if they're running into each other at church and, oh yeah, that was a great group by the other day. Oh wait, I'm not supposed to say that. If we can avoid that, and I know that can't always be avoided, but if possible, we try to make that happen.
Yeah. I know sometimes I was approached by clients in group who we had a new member come in and they knew that person, but they were getting ready to graduate, advance to the next group in another week or two. And they just opted to stay in the group. They just asked to not necessarily share about certain topics because they didn't want to have to move groups or have that person necessarily leave the group to draw attention to that. So too, I think it's meeting the client kind of what their needs are in certain situations and taking that kind of trauma-based approach. Other things that you guys have done to handle confidentiality within group?
Sometimes if I have a problem with confidentiality within the group when I'm running it and it's active, I will privately chat the person who might be breaching confidentiality, or there's something going on in their home or wherever they're at that is kind of disturbing the other group members as well. But I'll privately chat them, and it seems to work fairly well.
Yeah. That's a good idea too, Nancy.
Thank you. It works for me
As
too.
long as they're monitoring the chat.
Yeah, well,
Not everybody's lucky to have a Mitra.
sometimes we have some group members that are really active that way, especially if they don't want to speak.
Yeah.
Thanks.
Thank you. I know I kind of skimmed over it briefly, but it is, when we're thinking about interacting with staff and things like that, sometimes it can be, we can fall into the trap of feeling comfortable talking about certain things we shouldn't always talk about with support staff, but really being mindful of who we're talking to and what we're talking about. I was talking with Katie that, even when I'm teaching and I'm using a case example with teaching, I change gender, I change age to a certain degree, but where they're still within that same life cycle, change certain demographics. It's just hard to sometimes keep it straight in my head on who I'm talking about, but We really don't want to give away any of those identifying characteristics, or we violated that patient's confidentiality. Other questions or thoughts? Major, I think that might be the relatively last slide. I trust you.
That was the last one. And I was gonna say, you don't need a Mitra. You're monitoring the chat. Amazing.
And that's I'm spoiled at work. I have 2 monitors, and here I'm on an entirely too small of a laptop I bought online without looking at first. Any other thoughts about confidentiality?
Hey,
Sorry.
this is Jennifer Boyd. Can you hear me?
Yes.
Hey, thanks for the talk and the conversation. I'm curious more about confidentiality with respect to what topics are reasonable to bring up related to, the patient's care within the group setting. And we're all in person now, so it's not so much about that aspect of it, although it could be if we reverted back to telehealth. But so 2 things that come to mind. One is an example from my practice is if a patient discloses that to a staff member that they are Hep C positive. In general, I don't bring that up in group, although I will do at some point to give information about hepatitis C to the whole group, and then talk to that person privately. Another example is if someone brings something up during check-in, say with the nurse, then we meet as a team in huddle, and the nurse often reports that to the team. But I generally avoid repeating that in group unless the patient brings it up specifically, because it seems as though if they brought it up on a one-on-one setting, maybe something about a relation, another relationship that they have with someone, or something that's going on in their relationship or in their personal life or something like that. So anyway, could you just talk about what's fair to bring up in group? Or another example is relapses. I generally talk about relapse and disclose results of a drug screen in front of the group. And I feel like that's important, but I have certain patients who just seem exquisitely uncomfortable throughout group. And so that just adds an awkward dynamic, to bring up if something else shows up in the urine drug screen.
Yes. So I don't normally bring up, oh, Derek, you unmuted. I'll let you go first.
You already started, so you can go ahead.
No, it's the buffalo plaid has to go first.
I'm not, this is just maroon. I'm showing off.
Oh,
my
see,
Fairmont
it's the
State
small
mug.
screen.
No, those are good questions to bring up. I always kind of have the mindset of, what is the intent of that group? If it doesn't involve what's going on with the intent of that group, it might not be necessary to bring up. We do disclose urine drug screens in our group when we're going through things, more so just to try to encourage honesty. We'll kind of give them the chance to be like, hey, what are we going to see here? But if it is things outside of that, any kind of primary care, things that are discussed individually in counseling or one-on-one with providers, we'll give them the opportunity to bring it up if they want, but we're not going to try to probe at it. I'm sometimes get very passive, and I'll kind of drop hints at like, hey, I'm talking about that thing. If I want them to maybe start, sharing that with the group, especially if other people could benefit from it, but I'll totally 100% leave it up to them. I think at this point I'm rambling, so I don't know where I'm going with that. See, you should have went. You should have went first.
You nailed it. You nailed it. So I do think the psychoeducation piece is really important, especially when you're talking about things like Hep C, or different kind of medical things without necessarily pointing at an individual and saying, Sally Smith, your Hep C results came in, right? Like we shouldn't do that, but just having a general conversation or general treatment approaches, things like that. You know, if this is something you're struggling with, or you know somebody who's struggling with, here's a number that you can pass out to so they can receive treatment or get an appointment or an evaluation. I don't know if any of the docs on the call have other ways in how they handle that in their clinics or not. Not to put you on the spot.
Yeah, when we have our clients who are positive or have medical conditions, I let them take the lead. If they want to admit to the group that they're in Hep C treatment and they're doing great on it, that's fine. But that's not something I would bring up, because to me that's privileged medical information. But even sometimes stuff like hypertension and asthma and so forth, we talk a lot about those things as well. But it's just up to the person. Because some people will be very offended if you brought up their status to other group members, and they should be.
Yeah, I agree with that. Even psychiatric disorders, I don't reveal someone's psychiatric diagnosis to a group. If someone seems ill, I'll encourage them to get some attention, but I won't, discuss what's going on that's wrong, or, what the pathology is or anything like that.
Yeah, we share an orientation group that what we do ask them to be transparent with at all times with their treatment team. And when they're in group is where they're at with their sobriety days, and if there's been a recent slip or relapse. And then we let them know there's other things going on in your life that you want your team to know, but you don't want to bring it up in group, and you don't want us to bring it up in group. Feel free to reach out to us, send us a message, give us a call, say, hey, I want you to be aware about this going on, but I don't want to talk about that in group, and we'll absolutely honor that.
Dr. Husted, I see you unmuted.
Yeah, I will say the one thing we've done is kind of interesting is we set up a dual group. So I run the IOP program, and it's not uncommon for us to talk about mental illness and stuff beyond substance use in group. In the dual group, we've been much more open about that, discussing, and the idea is that pretty much everybody in dual group has a dual diagnosis. Otherwise, they wouldn't be in dual group. It's actually gone pretty well, though, in discussing it, similar to discussing addiction. So everybody struggles with anxiety or depression. So it hasn't been as bad. I could see how there'd be pitfalls and something you don't want to just nonchalantly bring up in group. But it's actually kind of helped people, I feel like, in at least the dual group. So if someone goes there, it's not always the worst thing in the world. And sometimes other people can relate to it and find ways it helps with their sobriety. So encouragement.
I think that ties into what Derek had mentioned. Just kind of letting the patients, if they bring it up, run with it. If not, then it's okay. But in that dual group, patients are going into that knowing what's asked of them, that they all have that some level of degree in common. Just like in MAT programs, they all have that in common. So being able to talk about it, or kind of what is the norm for that group.
You know what I found challenging? When I've had schizophrenics or schizoaffectives in groups, and I know at baseline they have auditory hallucinations, and then but I'm in group, I'm doing that check-in with everyone, asking how you doing, any problems, any emotional issues. I can't come out and say, hey, you hearing those voices today? Because to me that would breach confidentiality. However, as part of documentation, I'm like, well, I'm at a dilemma what to write, because I know they're having it, because I know them, but I didn't ask them that day in front of other people. What would you all do about that? How would you document?
Well, first of all, I think, by the way, Derek's laughing. He would definitely not ask them in group, hey, how are you doing with those voices?
No, I think that's totally what I would do.
I might actually.
No, we all are.
As far as documentation is concerned, you can write something like they did not report hallucinations, although previously they've been present, and or something like that.
Or did not appear to be responding to internal stimuli or things like that too.
But even though we know they are. Okay, thanks.
You can put they appear to be responding too. So now report, I mean, you could.
Yes, either or. Any other questions?
Nikki, I saw you had chatted and agreeing with everything beforehand. I just didn't know if you wanted to elaborate or anything, and no pressure if not. That's absolutely fine as well, but I wanted to see if you had anything else you wanted to add.
No, I was just agreeing. That's all.
That's awesome. Thank you. Phil, you seamlessly transitioned from your didactic into the discussion. So that was really cool. Thank you for that. Any other questions, comments, thoughts from the group?
Goal achieved.
I was just going to say, I think that safety is the most important thing in group format treatment. And if patients don't feel safe, they're not going to get any work done. So confidentiality kind of speaks to that safety issue. And of course, there's other things that can happen, like aggressive behavior in person and that kind of thing. But always keeping in mind, you want to create a safe culture for the patients.
That's a great comment. Thank you, Dr. Hirschler.
I want to apologize for not wearing buffalo plaid, but I have a buffalo plaid minion.
Oh my goodness, that's the best buffalo plaid one we've seen.
He's got googly eyes.
That's
That was
incredible.
It was a prank.
It's okay, Derek. I
Andrew.
totally thought you had it on from over here, so it's
Well, now I'm on the hunt for a floral shirt. I had to Google what that was.
You have to rock the floral and the buffalo plaid like Dr. Husted does. It's both at the same time. I'm loving it. Thank you.
Yeah, it's going to be a fashion trend someday. Just give it time. Yes, it will. Don't shake your head, Phil.
It's already trending in this group, so that's a good start. Any other comments, questions from the group? Alrighty, well, I can give you all 10 minutes back to your afternoon. So my only announcement is that the next time we'll meet is on June 13th, and Mark Groffley will be discussing buprenorphine, the misunderstood medication of the century, which sounds really interesting. So keep an eye out for that reminder. Big thank you to our case presenter, Margaret Karcher. We really appreciate you joining today, and you did such a wonderful job. And huge shout out to Phil West as well. We so appreciate you as such a superstar hub member. I was going to say super hub member, but either works. We really appreciate all the didactics you've given and such great engagement you've had with Project Echo. So thank you so much. And we hope to see you all next time. Take care.
Thank you. Bye.
Bye.